Maybe there is no Horatio Alger strategy here. It has to be more deeply rooted in communities in finding out where the origins lie and intervening as early as possible. And it's about education and economic and social inclusion, which means, I think, that we have to be advocates in a different way for health than we are for health care. And we need to combine the two, because I'm by no means suggesting that this is a competition where there are winners and losers. This is a synergy. And the message that we have learned in the last 15 years is that merely embedding population health vocabulary and goals into legislation, into strategic plans is not sufficient. We need people to embrace it at the ground level in the healthcare system, to give governments, to give communities the space to make those investments, even when healthcare can always use a little bit more. And that's a conversation, I think, that needs to take place in your lunchrooms, in your daily interactions with your patients, in your management meetings, in your practice improvement meetings. How do you marry these two concepts? How can we be serious about population health when there is still so much healthcare to do? And some of the ways you can do that are to get rid of the waste and useless work that we all do. I certainly spend a lot of my time doing wasteful and useless work, and it could always be improved. Healthcare, because it's so abundant, has many opportunities to do useless work. The great quality guru Don Berwick suggests that 30% of all healthcare systems, it's just frankly avoidable, useless work. I know it's a hard message to swallow. I don't know that we have empirical verification of that, but every alternative care day that is spent in the hospital, every avoidable readmission, every avoidable infection, every non-prevented flu epidemic because we didn't do the immunization, all of these things are preventable, all of these things are avoidable, and when we don't, they cause a tremendous amount of work. So avoiding needless work is one of the first duties of a healthcare worker these days. That too is a cultural transformation, but I think we can get there. Whose responsibility is it? Well, again, I think a key message I would like to leave you with is that it is widely distributed. It's everybody's, including the public's. And I think the lessons we've learned about previous attempts to change are that neither bottom-up nor top-down strategies work in isolation. And furthermore, if you have tools but you don't have policies to support them, your impact is going to be limited. And if you have wonderful sounding policy and vocabulary and you don't have the tools, then you're not going to get anywhere. So it is a multi-pronged effort to transform this. And I would urge you to invest in both acquiring the tools, but also invest your time and your minds and your thinking in terms of aligning the policies with the objectives you set for yourselves. So this is my last overbearing slide that attempts to simplify the world absurdly. But if we're going to have a grand unified theory of excellence, I think in terms of verbs, because above all, act. It's okay to fail. It's okay to try stuff and try it again. It's okay to mess something up because you've tried to make it better. There's lots of ingenuity in this room and throughout your LHIN if people will turn their minds loose in order just to try stuff to make it a little bit better. But I think if these are an oversimplified view of the world of what consists of a health community, these I think are what people have to do. The LHINs themselves have to govern and allocate and monitor and engage the public and educate and explain. The managers have to set goals, measure, empower, unify, account, and celebrate. The practitioners have to do those things. And the public has to get involved here, and I think whether the public does get involved here is going to depend on how much everybody else can inspire them to get involved and to get them to participate more fully. It's a daunting challenge, but it is a democratic and civic one that I hope you will embrace. And finally, this is what I want to avoid. I had to think, so what is Canada's problem? And again, this is a grotesque oversimplification, and it's a bit of a joke, but it isn't meant to be entirely amusing. It's sort of saying, so we talk a lot in Canada. We have 100 great health reports in Canada. We have a spectacular vocabulary of transformation, but we're kind of a bit slow getting going. So as I said, this is kind of a ratio so what is your action to talk ratio? And I've put us at the bottom of this table of 4 countries, and I would put New Zealand at the top. Because New Zealand, which does a whole lot of things I actually don't approve of in healthcare, but at least they do it. They will take a stand. They will say, all right, we've got a wait time problem, so we're going to have a point count system. If you don't make enough points, you're not going to get on the wait list. I'm not going to tell you that you're on the wait list, but wink at you and say, but you'll never get served. I'm just going to tell you you're cut off. don't approve, don't think it's a great way to do it, but they had the guts to try it. The UK makes policy all the time. I mean, it exhausts its system with health reform. They probably do too much of it in the UK, but at least they do it, and then they do it again when they mess it up. And you know what? Here we are in the UK now, which used to have the worst wait time problems in the Western world. If you phone for a doctor's appointment in the UK on a Monday in England, 99% of the time you will be offered an appointment by Wednesday throughout the entire country. And they didn't do it by doubling medical school enrollments. They did it by reorganizing practice. So they try stuff, they make policy, and so on. So my plea to you is to try to fill that bar in so that our action to talk ratio goes up to, say, 0.5 in a modestly Canadian way. I won't aspire to higher than that. But maybe someday we will pass New Zealand.
My question has to do with the comment about a third of the way through where you alluded to letting people do their thing and yet having some guidelines. Can you maybe speak to a few examples as to how you control the beast but while keep it chained? Is that the analogy, or however you want to use an example would be helpful?
Well, the general approach would be, if we are clear about what we want to achieve, say either a standard of care or a certain level of outcomes, I think that's what you should hold people accountable for. I mean, what we've tended to do in Canadian healthcare is, because we've been very vague about this, we don't set performance targets very well. So we've said, we don't have any of that stuff, but we're going to tell you exactly how to do your work. We're going to say, you know, the nurse to resident ratio in long-term care has to be 2 hours a day per yada, 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 yada. And we do all sorts of micromanaging of that while keeping our eye off the ball, which is, what are you trying to achieve here? And I'm just suggesting that we should reverse that. We should say, we should have 0 bed sores in hospitals. We should have an infection rate that goes down to X% and then continuously gets better. We think our readmission rate should be no higher than this. And then let the organization figure out how to do that.